Okay, disclosure-wise, my mentor, Chris Aarons, he always said the most dangerous aneurysm is a 4-centimeter one, because if you don't fix it, and actually it's true in this case, the guys next door will. So, medical management of aneurysms. I think this, one of the things when I talk to, students and general surgery residents about reasons to go into our specialty, I think that we've really had the opportunity within our specialty to find different ways to approach, common problems that we're all interested in. And I think what's been discovered by a lot of people much smarter than I am about the basic mechanisms of why aneurysms form, create a pool of interest and a niche for those of you in the room that are destined to study that. And I think that has long been something that folks can really make a big career out of. And I know probably right now at the stage most of you are at, you're probably thinking that you want as much open exposure as possible to fix an aneurysm and as much endovascular creativity and tools to be able to fix these to when they get to size. But if you really think about what 30 years from now is going to make a difference, it's probably something not related to a device that we'll be able to implant. I think just a couple of years ago I listened to a talk Steve Osterly gave. He's the chief scientific officer for Medtronic, used to be a cardiologist at Stanford, and he actually, somebody asked him the very astute question, in 20 years what was still going to be around from 2015 technology. And he actually said the only thing that would probably still be around from Medtronic's standpoint is the concept of starting from one place and going somewhere else to treat it. But that the actual delivery of whatever that is, stent or whatever, probably would be gone, and it would be some sort of either energy dispersed at that point or drug or something like that. But that the only thing we would still be doing is starting in one location in the body and getting somewhere else. So if you really think about that from over the last 30 years, talking about Mitchell showing the picture of DeBakey's first open aortic aneurysm to now how most of us probably treat it, we've actually come a long way. So anyways, this is from the Rutherford edition prior, with all of the different targets that one could use in order to arrest aneurysm development. So why would we even consider medical management? I think that has always been a long part of vascular surgery in terms of the multi-pronged approach. And as Dr. Lumsden sort of alluded to earlier this morning, there was a time when we even thought about changing our specialty name to Society for Vascular Specialists, because we wanted to let the public know that we weren't just about operating on people, that we actually thought about disease prevention, and such. And so obviously these are sometimes conflicting choices that we make, because obviously watching something or trying to intervene on something medically at the end of the day probably hinders us from doing what we all like to do, which is to operate on people. But certainly slowing the progression of any kind of disease is in an attempt to avoid operation. And so what is the ideal medical therapy? Well, what do we have now that we know reasonably, while maybe not in any randomized prospective fashion works? They are all things that make sense to us. And certainly from an epidemiologic standpoint, all of these things that we do could have an impact on longevity of a group or of a society or of a population. And so certainly, if you look at the aneurysm map, heat map within the United States, that nearly directly correlates to the amount of cigarettes smoked. And actually, for those of you that are trainees in California, California by far has the lowest smoking rate within the 50 states, and actually has the least number of aneurysms per capita of any of the states. So that is quite directly correlated, smoking with aneurysm. So certainly smoking cessation, probably the number one thing you can do on a day-to-day basis when you're seeing clinic patients. Exercise therapy, I'll touch into that a little bit. My boss right now, Ron Dahlman, has long been interested in exercise's influence on both things like diabetes and then how that translates to aneurysm progression. Beta blockade for a while was a really hot thing. There have been a lot of sort of attempted randomized trials outside of the U.S., some that got a lot of press, then some that turned out where some of the data was made up. So now it's a little bit fuzzy in terms of how to recommend that. Certainly, I think within the cardiovascular health sort of arena, beta blockers were thought initially to be the saving grace for all sort of perioperative events. Turned out some of that turned out to be a little bit falsified. So I think that has gotten a lot of sort of initially good press that's turned into some bad press. Statins, I think, I always kind of joke with the trainees that I think they're going to put statins in the water like they do fluoride. They're just, Big Brother's just going to decide that it's probably better for us. And then ACE inhibitors, certainly there's trials going on right now related to all of these medications to try to see if it can arrest or at least retard aneurysm progression. Genetic counseling, obviously, for some of the conditions that we know about that are associated with that, I think is an important aspect to medical management. Various trials have looked at smoking cessation. The UKSAT trial, really, tobacco use was the only sort of independent predictor of patients that were surveilled that had an increase in aneurysm size. And certainly, as we, as vascular surgeons, become more interested in thoracoabdominal and thoracic and moving up the arch, certainly smoking increases from both a basic science as well, or at the molecular level and such, definitely been correlated with increasing thoracoabdominal development, growth, and rupture, likely related to that first slide I showed with all of the basic mechanisms. This is some slides from Dahlman of some sort of epidemiologic things related to exercise and flow modeling that perhaps that by conditioning the aorta with exercise that you strengthen the ability or that you change how some of these molecules get laid down and the integrity of the remaining vessel. And again, this is work that he had done over the last several years that just sort of concluded both in an animal model as well as in a human randomized trial on daily supervised 30 minutes of exercise that had an influence on the progression of rats in this graph with aneurysms. And then it turned out that even when we randomized 140 to exercise versus usual care over the course of 3 years, that it turned out the exercise folks had a significant less stress and strain, if you think that is related to rupture risk, and so that probably is related to aneurysm progression, as well as the amount of peak sort of strain and stress that's on the aorta. And then it turns out the control group the control group that didn't exercise as much, that there was a slight decrease in the amount of AAA expansion. So the exercise group about 1.6 millimeters a year, and then the usual activity 1.8 millimeters a year. So that's exercise. So I think in general most people would agree that doing exercise is good for cardiovascular health, and I think we can add aneurysm to that for somebody with a small aneurysm. And I think I use that fact to just help educate the patients, because even when you see a patient that you're about to operate on and that you might need a couple of weeks to either get on the schedule or get pre-op, there is this perceived notion out there from their primary care doctor that they can't strain, or that if they strain or if they go to the gym to walk on the treadmill, that think that they'll actually burst their aneurysm while they're exercising. And I actually use a lot of this to say, actually, exercise probably at least while we wait a month to get you on the schedule, to order the fenestrated device, et cetera, et cetera, et cetera. They actually should be conditioning themselves not only for preparation for general anesthetic or for the stress of surgery, but that actually there actually is no downside to daily supervised exercise. So I actually will tell them they should be exercising through it. And I think that's something we can instruct our primary care referring providers about that. Beta blockers in animal studies, as well as these retrospective studies, have showed that it arrests aneurysm expansion rates. Unfortunately, not supported by randomized trials. And again, a lot of positive and negative press about beta blockers. Definitely, having put a lot of patients on beta blockers over the years, there are a lot of side effects from it, particularly when you first start. I think in general it's still okay for us to tell our primary care referring providers that if they can tolerate beta blockade, there are probably multiple protective effects when you talk about a population at whole. Certainly, we all know when you're in an acute setting, taking care of a dissection or somebody with an expanding aneurysm. We just this week transferred somebody over with a recently rapidly enlarging aneurysm, a contained rupture that we needed 24 hours to get sorted out anyways. And so while in the ICU, basically, as we were thinking about parameters to treat a contained rupture, you would treat that like a dissection. So beta blockade drip, keep the DPDT as low as possible, which generally means, and most ICUs will have a protocol for treating dissections, and I think the same thing holds true then for a symptomatic aneurysm, where I generally try to keep MAPs below about 65 and certainly try to keep the heart rate below 70. ACE inhibitors, there's been some sporadic interest in ACE inhibitors helping, but then in sort of other post-hoc analysis not been found to be helpful. I mean, these are all the things people talk about, and again, I think that when you go back to that first chart with all of the different sort of proteolytic reasons why aneurysms form for the scientists in the room, that's an area ripe for some innovative thinking and the ability to do that. Some of the newer things related to the renin-angiotensin system probably will have some sort of relation to that. Again, a lot of these aren't necessarily driven by us, but they're driven by the companies that make these drugs. But again, I think that is a useful avenue of sort of long-term, if that's what you're interested in research-wise. Doxycycline, there's a trial sponsored by Medtronic right now, the TEDDY trial, that's looking at variants of these types of antibiotics, the cyclin, so antibiotics that obviously we use from a microbiology standpoint to treat, walking pneumonias and a whole host of different diseases. And over the years, people have noted that there's probably some relation to degradation of the wall from bacteria. And I think, years and years ago, even before I was in training, I think people used to sample the walls all the time and send them for path and for micro, and they would find stuff that would grow out. And I actually just did an SMA open aneurysm 2 weeks ago, and we sent the wall, and actually the micro people called me and they're like, "What, do you think this is infected?" I said, "No, actually I was just academically curious what might grow out." And they were like, "Oh, nothing's going to grow out." And I said, "I'm asking you to grow it and see what happens." And it actually grew out C pneumonia. And probably at some point on an SMA aneurysm, somebody gets a bout of walking pneumonia, they get some bacterial seeding to some vasovasorium, the wall weakens, and then 10 years later you got an SMA aneurysm. A bunch of other antibiotics that people have been using related to that. Statins, again, some pluses or minuses depending on how you look at it. I think certainly we haven't discovered all of the reasons why statins work. I think definitely statin and any vascular surgery procedure probably has a better outcome, durability of an open repair, durability of a bypass, durability of a bare metal stent, of a drug-eluting stent. I think outcomes, long-term cardiovascular survival, I think nearly everything has been shown to be positively influenced by statins. So I think if our patients can tolerate a statin from a liver standpoint and from a healthcare cost system standpoint, like I said, I think if it were up to us one day to be in charge of it, you'd just put it in the water like fluoride. So. There's some mechanism I don't think anybody really understands yet. It's probably an anti-inflammatory effect. A lot of patients will tell me, my cholesterol's back to normal again. Do I have to keep taking this drug? Because I think most patients don't want to take drugs if they don't have to. But I think really there's something we don't understand yet about statins that has a positive influence. And then obviously the last part I talked about was sort of the genetics of things. And so people that have genetic disorders have some targeted medical things that in general most of the institutions that you're at will have a MARFan trans clinic or have a connective tissue disease clinic. So that's mainly related to sort of the aneurysm stuff. There's a lot of interest. This is a good way to collaborate, I think, with vascular medicine and scientists at other places. That's been rich for us to work closely with some people that we normally wouldn't have worked with in terms of people who are non-sort of interventionalists, and we've been heavily involved in finding patients with small aneurysms to try some of these immune modulation type things. A lot of studies going on related to that right now, all with mixed sort of results. But again, if you're interested in this, if you think about it, the most ideal person to actually look at the basic mechanism of this is somebody who also then has some in the game related to treating the aneurysm.